So let's take this from the top. So we do have some students that are in hybrid paramedic getting ready for their midterm, and then obviously we have some seated students preparing for your final. So this information will be beneficial to both of you. I shared this document with both of you, and I had someone ask me yesterday, so I'll just clarify. The midterm and the final exam are not going to be open-ended questions like this. They will be multiple choice, just like they always have been. The reason I did the study guide this way was just simply so that you could see what information you needed to look over, and force you to really look up the information or study it that way without just giving you express question and answer choices, obviously, because that would be sharing the test with you. So we don't want to do that. So I'm going to start from the top and go through this, because with all the answers, as you can see, this is 14 pages. So it's going to take me a little while to go over all of this. If you have got to step out and come back, that's fine too. So just stay for as long as you can. But like I said, if you have a question, feel free to shout it out or type it into the chat. But I'm just going to go over some of this stuff here. So starting at the very top, looking at some different types of shock and some potential treatments. So we have got hypovolemic shock. And of course, that's going to be from a loss of volume, like blood or fluid. So that is a volume problem. And then we have two types of hypovolemic shock. We have hemorrhagic, which is obviously going to be related to a loss of blood, and non-hemorrhagic, which is going to be loss of fluids, not blood, like vomiting, diarrhea for long periods of time. And then the treatment for that, if it was hemorrhagic, obviously blood's going to be our gold standard of replacement. In the absence of that, we may be able to give some type of fluid bolus, but want to be cautious there, because remember, the fluid cannot do what blood can do in the sense that it can't carry oxygen, nutrients, remove waste products, all of that stuff. So we don't want to water down the blood that we do have available to us. And then if this is a like internal bleeding issue, or even if it's external bleeding, if it's trauma, they may need surgery to help stop that bleeding as well. And then for non-hemorrhagic shock, again, fluid replacement may be beneficial here as well. It just kind of depends on why they lost the volume as to what's going to be the best way to treat that. Moving down, we have a little bit of a widespread category, which is going to be for distributive shock. And this is going to be related to widespread vasodilation, and that is a container problem. Now, there's a lot of subcategories there under distributive shock, and each one has its very own specific treatment. So we'll take a look at some of those. So under that distributive shock category, where we're experiencing that widespread vasodilation, this can come from a lot of different things. It can come from neurogenic shock, which would be widespread vasodilation from the point of injury down, and this is coming from damage to the spinal cord. The treatment here is going to be, of course, just manual stabilization and spinal immobilization there, and then in some cases may include some high-dose corticosteroids like Solumedrol, but that's protocol dependent. And again, as far as definitive treatment at the hospital, is the abnormal sensation, loss of temperature control, and or paralysis. Is that temporary? Is it permanent? They may need surgery to assist with that as well. Psychogenic shock is our temporary widespread vasodilation, and temporary is the key word there. This is like a syncopal episode, usually caused by some type of emotional upset, causing that widespread vasodilation. And again, this is the only type of shock that will reverse without any intervention from you. The care is mostly supportive here, and then ensuring that they did not have any trauma during the fall when they passed out. And then also just clarifying that that's what it came from, that it was from just the emotional upset, that they weren't feeling dizzy or having heart palpitations or have a low blood sugar or, anything like that that could have contributed to the syncope. Next there under distributive is anaphylactic shock. And so this is our widespread vasodilation from systemic allergic reactions. It may present with hypotension, wheezing, hives, stridor, angioedema, so swelling of the face, lips, and tongue. Those are just a few examples that come along with anaphylaxis. And of course, our treatment there, first and foremost, should be that we are managing with our epinephrine. So epi 1 to 1,000 given IM. at 0.3 to 0.5 for the adult dose. That needs to be your first line medication when we're talking about anaphylaxis. There are other medications we're going to talk about here in just a second that can help with the other symptoms that we're experiencing, but that is going to be your life-saving medication. You're going to get your vasoconstrictive and bronchodilator properties from that. So we want to make sure that we are leading with that. We can also consider 25 to 50 milligrams of Benadryl, IV or IM. Of course, you could give it PO too if you had it PO, but again, considering is the airway swollen, can they swallow adequately? And most places generally don't carry PO Benadryl because it's just much easier, more cost effective to carry it to be given as an injection. And then if the wheezing is persistent, again, we can give 2.5 to 5 milligrams of albuterol nebulized, and we could do that with or without 0.5 milligrams of Atrovent as well. And then depending on the severity and what you feel is going to be beneficial for the patient, we could also follow up with 125 milligrams of Solumedrol IM or IV. Now, why the Solumedrol? Because we're not going to see any immediate effects from that, right? But when we think about the phases of anaphylaxis, we need to treat this, but then of course we want to keep those symptoms suppressed, and that Solumedrol is going to do that. So we actually don't see the peak effects of Solumedrol for about 2 days, but still important that we go ahead and give that if we suspect that this is, life-threatening. Next, underneath that, we have septic shock, which is our widespread vasodilation from a systemic infection. So looking at the Sears criteria, remember that's going to be either an increase or a decrease in temperature. So they have a fever or they are very hypothermic, combined with an increase in heart rate, decrease in blood pressure, decrease in end tidal. And then we also have that potential, even though it's not part of the Sears criteria, for an increase in blood sugar and an altered mental status to go along with this as well. So remember, is the temperature either too high or too low, combined with any of the following. Doesn't have to be all of the following, but any of the following there on the heart rate, blood pressure, and end tidal. So what's leading us down this path? Known or suspected infection. And of course, thinking about things that aren't as obvious. If they have an infected wound, that's going to be obvious to you. Recent surgery, if you can see redness and inflammation around the surgical site, that could be a red flag for you, but also thinking about things that are less obvious like UTIs. So treatment here for sepsis is going to be a high volume fluid bolus as long as the patient can tolerate that, right? We want to make sure we're checking our lung sounds between the administration of fluid there, making sure we're not giving too much and overloading the patient, but a max of 2 liters. And obviously the definitive treatment at the hospital is going to be some type of antibiotic to help treat that underlying infection. Then moving down to the next types of shock that we have here, these are obstructive shocks. And so this is an anatomical blockage of vessels of the heart leading to decreased venous return. So this is a pump problem. This is a problem with the heart itself or obstructing that blood flow to the heart. So some of these here, tension pneumothorax, so things you could be looking for, known or suspected blunt or penetrating chest trauma are going to be the most likely cause. This can happen spontaneously in some cases. We're thinking about tall, thin, white males being most at risk for spontaneous pneumothorax. It could also come from a medical condition if we have that weakening or bleb there inside of the lung tissue. But it's going to present with diminished or absent lung sounds on the affected side. And if it becomes severe enough, can lead to tracheal deviation or tracheal tugging. So remember, if we start out with those diminished or absent lung sounds on one side and no intervention is performed to help relieve that pressure, it's going to continue to build. And as it continues to build, it's going to start compressing over to the other lung. It's going to take the trachea with it. So that's where we see the tracheal deviation with that. And can also start to compress the heart as well. So that's why it's an obstructive type of shock, not just affecting the lungs, but the potential for the heart as well. Our treatment, they're going to be needle decompression. So obviously my students gearing up for finals know how to perform that. Students for midterm have not yet gotten to that part, but you should at least know what the treatment is, even if you don't know how to do it just yet. Next one under obstructive shock is going to be cardiac tamponade. So that's known or suspected blunt or penetrating chest trauma. Again, most likely cause. And then may have some bruising there over the left chest wall over top of the heart, but this is where the pericardial sac is either damaged or punctured and begins to retain blood or fluid around the heart that is preventing it from pumping normally. So this patient may present with Beck's triad, and so Beck's triad is going to be JVD or jugular vein distension, muffled heart tones, and our narrowing pulse pressure, which means that our systolic and diastolic blood pressure readings are getting closer together with trending vital signs. So not just that I take one blood pressure and the numbers are fairly close together, but meaning that my top number is getting smaller and my bottom number is getting bigger each time. They're getting closer and closer together. That's my narrowing pulse pressure. Now, obviously, this would only be applicable if you find the patient who it still has a pulse. If the patient is in cardiac arrest when you find them, then you're really just kind of looking for that history of potential chest trauma, maybe some bruising there, what kind of injury occurred, because you're not going to be able to see any of these things. You're not going to be able to see JVD, hear muffled heart tones, or see a narrowing pulse pressure in a cardiac arrest. Now, the definitive treatment for cardiac tamponade is a pericardial centesis, and remember, this cannot be performed in the pre-hospital setting. This is a definitive treatment performed at the hospital by a doctor. So our care in the pre-hospital world is usually just going to be supportive. Moving on to our next type of obstructive shock, we have thrombosis or pulmonary embolism. So this is a blood clot that is obstructing the blood flow through the heart and or lungs. So the risk factors can include recent surgeries, women taking birth control, sedentary lifestyle, history of clotting disorders, or prescription for blood thinning medications. Treatment is going to be dependent on the location and the severity of the clot. It may be treated in the hospital with a mechanical thrombectomy to remove the clot or clot busting medications. Not again a ton that we can do in the pre-hospital setting other than just make an educated guess based on the patient's signs, symptoms, and presentation and history that this is what's going on, and then provide supportive care. And then we have cardiogenic shock, which is acute heart failure. It's most often caused within 72 hours following a STEMI, but it can stem from other causes that have weakened the heart, so it is a pump problem. And the treatment here, depending on the severity and the presentation, the patient may require CPAP if they have severe pulmonary edema, but the patient may also require vasoconstricting medications, focusing on increasing the force of contractility more than the heart rate, and that would be something like Levophed. So moving on to number 2, we have the parts of the perfusion triangle, which we really just kind of talked about with different types of shock. So we have the heart, which is our pump. We have our blood vessels, which are the container. And then we have our blood or fluid, which is going to be our volume. So again, if you go back and kind of pair those parts of the perfusion triangle up with all of these different types of shock, that should hopefully make sense to you. Number 3, what are the correct methods for treating a foreign body airway obstruction in the following situations? So of course we have the conscious adult. If this is a partial obstruction, meaning that they are still coughing, or you can hear stridor, they are moving some kind of air. And obviously we don't want to make that any worse, so here we would just want to encourage coughing. But if this is a complete obstruction where there is no coughing, they're unable to speak, no air movement at all, we're going to do the Heimlich maneuver, and we're going to repeat that until the object is removed or the patient becomes unresponsive. If they do become unresponsive, then we move down to the next piece, which is the unconscious adult. And here we would want to begin CPR regardless of the presence of a pulse, all right? Because remember, that's not why we're doing this. We're doing this to try to force that foreign body out. So we do want to assess the airway prior to ventilations each time to determine if the object has become dislodged. If you can see it there inside of the mouth, then you may be able to remove it, like with McGill forceps. But if you can't see it, don't stick your fingers in there because you risk pushing it further down. For the conscious infant, if it's a partial obstruction, difficult to kind of encourage coughing for an infant because they really can't follow instructions, but you don't want to do anything that could, again, potentially push the object back down. So if you can't see the object, don't stick your fingers in their mouth or try to remove it. But if it is a complete obstruction, so they are awake but not moving any air, maybe turning cyanotic, not breathing, we want to do the 5 back blows and 5 chest thrusts, alternating and repeating until the object is removed or they become unresponsive. And then again, if they become unresponsive, then we want to begin CPR regardless of the presence of a pulse, and we are assessing the airway prior to ventilations each time to again determine if that object has become dislodged and we can remove it. Moving down to number 4, we're going to look at a couple of terms here, and this is more related to OBGYN stuff. So just kind of defining the term miscarriage, which can also be called a spontaneous abortion. So this is the expulsion of a fetus from the womb before it's able to survive independently, and typically presents with bilateral lower abdominal pain, cramping, and vaginal bleeding. Typically, this does occur before 20 weeks gestation. Past 20 weeks, there's some potential for viability, but again, this is happening spontaneously. This is not induced abortion. Don't be confused by that term. So spontaneous abortion is the same as a miscarriage. Now, an ovarian cyst, this is a fluid-filled sac or pocket in an ovary or on its surface. It may not present with any symptoms until it starts to rupture. That's where it may cause you the most pain, but it can cause menstrual irregularities, pain during intercourse, irregular bowel movements, and if it begins to rupture, it usually causes unilateral, so only on one side, lower abdominal pain, because the pain is going to be on whatever ovary the cyst is on. With endometriosis, this is a disorder in which tissue that normally lines the uterus grows outside of the uterus, so it can affect the ovaries, the fallopian tubes, or the intestines. Those are the most common sites that this tissue overgrowth would occur at, and it can cause severe pain and menstrual irregularities. For ectopic pregnancy, this is a pregnancy in which the fetus develops outside of the uterus. Now, that can be in other locations, but most commonly it is in the fallopian tube. And this may not present with any symptoms of abnormal pregnancy until it ruptures. So this is going to give you pregnancy symptoms, positive pregnancy test, missed period, all of the things indicating a viable pregnancy until the fallopian tube ruptures. So as the fetus continues to grow, then it's going to get larger and larger, so much so that the tube cannot hold it, and then that's where it's going to rupture, and that's where you have the pain. So this is going to present with severe unilateral lower abdominal pain and possibly vaginal bleeding, and it is the most common cause of maternal death in the first trimester. So that's significant for us to be able to be suspicious of, treat, and recognize. Number 5, what is humidified oxygen and when can it be used? So this is oxygen that just has humidified water attached to it, and it reduces the sensation of dryness in the upper airway. It's most beneficial to moisten the airway, like in cases of stridor that are not related to anaphylaxis, and long-term oxygen use or transport. So if you know someone who's on home oxygen, they probably have an oxygen humidifier where they put water into it. Inside of that every single day, or every couple of days, to moisten up that air that they are going to be breathing in. And we can create this in an EMS setting with using saline or sterile water inside of the nebulizer. So we would set it up, but instead of putting medication inside of the nebulizer chamber, we would put that saline or sterile water and run the nebulizer as we normally would with the face mask. And this can give us that sensation of humidified oxygen. Number 6, what is the normal pH of the human body? And that is 7.35 to 7.45. So that's the normal pH of blood. And remember, any deviation from that, if we are going to, even a little bit on either side of that, is really going to be non-conducive with normal life. You're going to start having issues with oxygen binding to hemoglobin. You're going to start having issues with medications acting the way that they should. And so it's going to start leading to some other things, which we're going to talk about here in just a little bit, with different types of acidosis or alkalosis. So what is a bicarbonate buffer system? That's also related to acid-base balance. So the acid-base homeostatic mechanism involving the balance of our bicarbonate, which is HCO3, and carbon dioxide or CO2, to maintain that pH in the blood to help support normal metabolic function. So that's kind of where bicarb comes into play, is to neutralize those acids and keep that pH normal. And I'll go into a little bit more depth with that when we get to the area that's asking about metabolic and respiratory acidosis and alkalosis. So number 8, how can hyperglycemic, hyperosmolar, non-ketoacidosis lead to dehydration? So as the body tries to rid itself of that excess sugar in the blood, it's going to pass it over to the urine, and this is going to contribute to dehydration. So if it can't be utilized by the cells, then it is going to be passed out through the body, usually through the kidneys in the form of urine, and this can cause the person to become dehydrated even if they are bringing in excess fluid. So we'll talk a little bit more about the 3 Ps in just a little while in relation to diabetes and how those kind of things kind of play together, but that's how this can easily lead to someone being dehydrated even if it seems that they are drinking normally. Number 9, what are the signs and symptoms of appendicitis? So right lower quadrant pain, positive rebound tenderness. So remember, rebound tenderness means I'm pushing in on the area and that makes it feel better, and it hurts worse when I let go. That's different than just normal tenderness on palpation. Pain will typically worsen with movement, and then the patient may also have nausea, vomiting, loss of appetite, and in some cases fever. Fever is going to be present more if the appendix is really inflamed or infected, or if it has ruptured, because obviously then we're going to be spilling those contents into the abdominal cavity. Looking at number 10, what are the signs and symptoms of diverticulitis? So inflammation or infection in one or more pouches in the digestive tract or intestines. So abdominal pain, typically in the lower left quadrant, and nausea, vomiting, fever, constipation. On the flip side of that, less commonly but still possible, is diarrhea. So basically, when we have these little pouches there inside of the intestines that become trapped with fecal matter and it becomes impacted there, not able to pass, just kind of gets caught up, and if it's not able to leave and it sits there just kind of rotting and leads to infection. Number 11, what are some risk factors for increased risk of suicide? John McBurney sign is usually related to your gallbladder, and I did not put that on here, but I can talk a little bit more about it towards the end. I can throw that on there after we take a break. So number 11, some risk factors increase risk of suicide. Previous suicide attempt, substance abuse, mental health disorders like anxiety, depression, PTSD, access to a lethal means. So if they have weapons in their home, family history of suicide, social isolation, chronic or terminal disease or disability, financial issues, job loss, loss of a spouse, sudden improvement from previous depressive episodes. So it seems like things are getting better and then suddenly they become worse. Number 12, provide examples of the following types of medications and explain what they are used for. So obviously I did not list all of the million types or names of different medications, but I gave you a few here. So for the beta agonist, we have this being a bronchodilator medication that opens the airways by relaxing the muscles around the airways that may tighten during bronchospasm. And this example could be like albuterol or the trade name of Ventolin. And what is it used for? That's going to be wheezing or bronchospasm, and that could be related to asthma, COPD exacerbation, pneumonia, or anaphylaxis. Those are some of the most common times that we would see that. A sodium channel blocker. So this is a class of drug that acts by inhibition of a sodium influx through the cell membranes. So the blockade of the sodium channel slows the rate and amplitude of the initial rapid depolarization, reducing the cell excitability and reduces conduction velocity. I'm not going to try to read those names there, but you'll see them listed. And what is it used for? It could be used for angina, cardiac arrhythmias, heart failure, systemic and pulmonary hypertension, and also epilepsy. And that's a big one there because that reduces cell excitability, not just in the heart rate when we're thinking about it controlling the rate when we think about arrhythmias, but also epilepsy to control that cell excitability and how we think about that rapid spread of potential. Calcium channel blockers, these are a group of medications that limit how your body uses the essential mineral calcium. So it can be specific or targeted to the area where calcium typically exists in only certain parts of the body. So some examples of those we are kind of familiar with, like amlodipine, Norvasc, diltiazem or cardizem, and verapamil. So it can be used to treat hypertension, arrhythmias, specifically like atrial fibrillation and pulmonary hypertension. And then the potassium channel blocker, less commonly talked about in a pre-hospital setting, but this is a class of drug used for treating arrhythmias and can also improve movement in people with multiple sclerosis, where nerve cells have lost those myelin sheets. That process is known as demyelination. And the potassium channel blocker helps prolong the duration of the action potential. And so those are some examples of the medication, and again, can be used for multiple sclerosis and also some arrhythmias. Moving on to 13, so what are renal calculi and how would you treat this in a patient if they were symptomatic? So renal calculi are kidney stones, and you could consider an analgesic medication like morphine or fentanyl, of course, but you should use those in addition to, if you feel they are necessary, to ketorolac or Toradol. That's going to be your treatment of choice for someone that we suspect has a kidney stone, because remember, it's got the analgesic property even though it's not a narcotic, but the biggest thing here is the inflammatory piece. And so this has those anti-inflammatory properties. Think about it like a souped up aspirin or ibuprofen that's going to help reduce the inflammation of their ureters and allow the kidney stone to be able to pass. And so also giving a fluid bolus here can help pass that kidney stone along as well, and also rehydrate the patient, because a lot of times kidney stones form as a result of dehydration. So this is really painful. I have new respect for kidney stones after I had one myself. So for example, when we think about our most painful things for women, we usually say childbirth being your 10 out of 10, and childbirth was my 10 out of 10 until I had a kidney stone, and then I say my childbirth is more like a 5 and my kidney stone is my new 10. So that's saying something. So do not discredit this pain. If the patient has that flank pain radiating around to the lower abdomen, pain in the groin, especially for males, if it is painful sensation with urination, things like that, could definitely be this renal calculi. Looking at 14, so what is the Office of EMS protocol recommendation for blood sugar reading of a hypoglycemic patient to receive treatment, and what are 3 methods you could utilize for treatment of a hypoglycemic patient? So they are recommending treatment of hypoglycemia with a blood sugar finger stick of less than 69. Of course, this could be patient dependent depending on what's normal for them, because if their blood sugar is normally really high, they could start feeling bad at 100. Even though that might be normal for someone else. So again, patient dependent, but that's the recommendation at 69. Administration of dextrose 10% or D10, titrated to effect, usually about 125 to 250 mLs will get you right where you need to be. Could also be glucagon, which would be 1 milligram IM given here if you're not able to get an IV to give that dextrose. And if the patient is able to eat and drink and swallow appropriately, follow commands, have a good mental status, then we may just simply be able to have them eat or drink or give oral glucose. I didn't put that on the list, but that's certainly an option as well to try to treat that hypoglycemia. So it really just kind of depends on what's going on with the patient, what kind of IV access you can get, how severe are their symptoms, what's their mental status, and their ability to eat and drink normally. So 15, what is the OEMS protocol recommendation for a blood sugar reading for a hyperglycemic patient to receive treatment, and what treatment will be most beneficial that we can administer in the pre-hospital setting? So again, Office of EMS recommends treatment for hyperglycemia with a blood sugar reading of 250 or higher, but again, that may be patient dependent. If they are not symptomatic with a blood sugar over 250 and you check it and they say, yeah, that's normal for me, then you may not be required to administer any type of treatment. You would just document that in your report why you did not. So again, all patient dependent, but if they are symptomatic and you are going to treat it, then fluid bolus is going to be your best option. Make sure you're monitoring, again, lung sounds as always if we are giving a fluid bolus. Insulin is going to be the definitive treatment, likely administered at the hospital, and the patient may have already done this for themselves. If they have, then document that in your report. But insulin typically not carried on most pre-hospital ambulances, but fluid bolus is going to help reduce that glucose serum. All right, 16. What are 3 ways that you can use to confirm good compliance with ventilations? Of course, a lot of things you could say here. 3 I chose to talk about were chest rise and fall, lung sounds, and gastric sounds. So again, we can also say are we just getting good compliance with the BVM? Is it difficult to bag, or is it easy to bag? Does it feel like we're meeting resistance? So a lot of different things that you could say there. Just make sure you're familiar with some ways that you can confirm you're getting good compliance with BVM ventilation. 17, what are 3 ways that we can confirm tube placement following insertion of an ET tube? So remember that anytime we're using an advanced airway, whether it is a supraglottic or an ET tube, in North Carolina, it is mandatory that we are using end-tidal for confirmation. Now, that does not have to be a continuous feedback giving you the number and the waveform. I'll talk about the difference in just a second, but it can be a color change, but you've got to use some type of end-tidal to confirm placement. Other things we can use that are specific to ET tube placement would be visualization of the tube passing the cords, condensation in the tube, and then of course going back to Old Faithful, which is lung sounds and chest rise and fall. But we really want to use at least 3 methods of tube confirmation anytime that we are managing the airway like that. All right, so we mentioned pH earlier. I told you we'd get a little bit more in depth with it, and here we are. So we have looking at the following: metabolic acidosis. So the patient does not have enough acid being used in the body or does not have enough blood circulating, so the acid has begun to build up. This can present with tachycardia, pulmonary edema, tachypnea, confusion, altered level of consciousness, and may be caused by cardiac arrest, renal failure, DKA, and dehydration, like with diarrhea for long periods of time. And it is going to have a decreased pH, decreased bicarb levels, which remember is HCO3, and typically a normal EtCO2. But again, you kind of have to look at it, because if it was respiratory acidosis that led to the metabolic acidosis, then that may not be the case. You may have a decrease in pH, decrease in bicarb, and a increase in end-tidal. So you really have to kind of look at the cause there. With metabolic alkalosis, the patient has a buildup of bicarb and not enough acid in the bloodstream, and this can present with seizures, headache, cardiac dysrhythmias, and it can be caused by use of diuretics, cystic fibrosis, chewing tobacco, particularly if you swallow it, penicillin, and overzealous or unneeded bicarb administration. So we give that bicarb, didn't need to, and now we've got these symptoms. Typically here we're going to see an increase in pH, increase in bicarb, and a normal end-tidal. So remember when we went over acid-base balance, we used that term ROME, so respiratory opposite, metabolic equal. So when we talk about respiratory, we're going to talk about what's opposite, but here in metabolic issues, we see where we saw a decrease in pH, we also saw a decrease in bicarb. Those things are equal. We saw an increase in pH, we saw an increase in bicarb. That's equal. And then on the respiratory side of things, with respiratory acidosis, if the patient is not breathing adequately and is retaining CO2, so there's an issue with their rate, rhythm, or quality of ventilation, it could be caused by respiratory insufficiency from COPD, overdose, pneumonia, smoke inhalation, pneumothorax, airway obstruction, etc. But this is going to present usually with an altered level of consciousness, tachycardia, diaphoresis, headache. And here we're going to see a decrease in pH, increase in end-tidal, and a normal bicarb. So those are opposite. The decrease in pH is opposite from the increase in end-tidal. And then with the respiratory alkalosis, this patient is getting rid of too much CO2 from hyperventilation. So when there's not enough CO2 in the blood, the body is using bicarb to compensate from the lack of respiratory acid, and this is called metabolic compensation. And this can present with numbness or muscle twitching in the fingers, toes, hands, feet, and possibly seizures. Could be caused by hyperventilation, caused by shock, DKA, anxiety, pain, fear, hypoxia, fever, sepsis, etc. And here we typically see an increase in pH, decrease in end-tidal, and normal bicarb levels. If you have a question, please feel free to stop me. I don't want to keep going if you're confused, but as long as everybody's good, I'm going to keep going. So 19, explaining the difference between stable and unstable angina. So stable angina typically is predictable following exertion, so the increase in oxygen demand of the heart there. And it's relieved in most cases with rest and or nitroglycerin when the body is then able to meet that increased oxygen demand, so the pain stops. The unstable angina typically comes on at rest or without exertion or increase of oxygen demand, and is typically not relieved by rest or nitroglycerin, at least not right away. Looking at number 20, which areas of the heart do the following vessels feed? So the left anterior descending usually feeds your septal, anterior, and lateral. So those are going to be the biggest areas. The left circumflex can feed the lateral and possibly the posterior. And then your right coronary artery typically is feeding your inferior area, possibly the posterior as well, which again, we can look for those posterior areas to kind of check and see if with a 15 lead and see if there's any posterior involvement, and also using that 15 lead to kind of tell us, is there any right ventricular involvement. So looking at the following terms here, usually related to allergic reactions. So we have pruritus, which is severe itching of the skin. We have wheal, which is a red swollen mark on the skin like a bite or a sting. And then urticaria, which is a rash of round red welts on the skin that itch intensely, sometimes with dangerous swelling, and that's usually referred to as hives. So just know what those terms mean there. Moving down to 22, what are the two types of stroke, and which of these might be prefaced by a TIA? We have the ischemic stroke, which is caused by a blockage or a clot in a vessel. And this is the only one that can be prefaced by a TIA if the symptoms resolve within 24 hours without treatment because the clot has moved. So again, think about the opposite of that being that a hemorrhagic stroke is caused by an active bleed in the brain from like a head trauma, aneurysm, something like that. You can't stop that bleeding on its own for those symptoms to resolve. The clot can move. So if you have a clot there and presenting with stroke-like symptoms and then those resolve on the way to the hospital or within an hour or two or less than 24 hours without treatment, then that's probably a TIA. Now, again, a TIA doesn't mean there's nothing wrong. Doesn't mean that they don't need additional treatment because there still is a clot there. There's still a problem. And we don't know next time if those symptoms start, if they are going to resolve on their own. So without a CT scan, we really cannot differentiate between either type of stroke or if this is a TIA. We can be suspicious of if it's ischemic or hemorrhagic based on their history and the environment, but we really need a CT scan. But luckily for us, our treatment for strokes are going to be the same, and that's mostly supportive care and rapid transport to an appropriate facility. So what's the difference between left and right heart failure, and what are some potential causes of each? So left side heart failure means that the heart has lost its ability to push blood out of the heart to the rest of the body effectively, causing blood and fluid to back up into the lungs. This is usually caused by coronary artery disease, heart attacks. Remember, we talked about cardiogenic shock, 72 hours post-STEMI being most at risk there for that pulmonary edema coming from that cardiogenic shock, and prolonged hypertension. Now, right-sided heart failure means the heart has lost its ability to pump blood into the lungs to be reoxygenated, and so blood begins to back up into the body. And this is most often caused by left-sided heart failure because as blood backs up from the left side into the pulmonary artery, the right side of the heart also has to work harder to move the blood to the left side. It can also be caused by coronary artery disease, heart valve abnormalities, long-term hypertension, particularly pulmonary hypertension caused by COPD or other respiratory conditions. When we think about with right-sided heart failure, where we see that pedal edema, weight gain, abdominal swelling, things like that, where we see that back up in the rest of the body. Now, a patient can be presenting with both, of course. We could have both right and left. But if we have that pulmonary edema without the presence of, pedal edema or swelling in the abdomen or unexplained weight gain, that does not discredit the fact that they still need treatment or that they have something serious going on. It just means that the right side of their heart is probably not yet failing, which is good for them. Now, looking at 24, how would you describe the following lung sounds and what conditions may present with these lung sounds? Now, obviously, I can describe them, till I'm blue in the face, but until you've listened to them, until you've heard them and created your own kind of way to analyze and describe those, it might not mean much to you. Wheezing is technically described as a high-pitched hissing sound heard more frequently on expiration, but can also be heard on inspiration. And as we previously discussed, this is usually coming from bronchospasm related to asthma, COPD, anaphylaxis, and it can also be heard with pneumonia. Now, pneumonia can produce a lot of these lung sounds, so don't let that part throw you off. It really just kind of depends on the severity of the pneumonia, how long have they had it, has mucus formed, that type of thing. Now, rales is going to be our low-pitched bubbling, popping, or crackling sound heard in the lungs that indicates fluid. And we typically hear this with congestive heart failure, pulmonary edema, can also be heard with pneumonia as well. And then rhonchi is going to be our low-pitched, coarse sound indicating thick mucus. So this is going to be like a fine bubbling, crackling. This is going to be like thick mucus, coughing up, productive cough type sound with rhonchi that we're hearing there inside of the lungs. And so that usually presents with bronchitis. It could be chronic for someone with COPD who's got the chronic bronchitis side of COPD. If we break COPD down and look at the two types, chronic bronchitis and emphysema, most people do have both, but the chronic bronchitis side of that is going to produce this thick mucus all the time, and that could be normal for them. And then, of course, pneumonia again. And then stridor being our high-pitched whistling sound, typically heard on inspiration, indicating a narrowing of the upper airway. And so this could be coming from some type of occlusion of that upper airway above the trachea. So anaphylaxis, foreign body obstruction, croup, epiglottitis, airway burns, all of these have the potential to occlude that upper airway and produce that stridor sound. Looking at 25, what is an aortic aneurysm and how might a patient present with a dissecting aortic aneurysm? So an aortic aneurysm is that balloon-like bulge. And remember, aneurysms can happen anywhere inside of the body, but they are most common to happen in the brain, around our cardiac vessels, especially the aorta. And so this balloon-like bulge begins to form in that weak spot, and blood begins to collect, and it just grows and grows and grows until it's either removed or it ruptures. So of course, the aorta being the large artery carrying blood from the heart through the chest and the torso. And prior to rupture or dissection, the symptoms may include chest or abdominal pain, pain in the lower back, pulsating mass in the upper abdomen, a discrepancy between blood pressure in the right and the left arm. And once it dissects or ruptures, typically it's going to present with sharp or sudden pain that's maximal at onset, meaning it's as bad as it's going to get right from the get-go in comparison to other types of chest pain that can wax and wane or get better and worse. This is going to be as bad as it's going to get right from the beginning. And the patient usually uses these terms to describe that pain: ripping or tearing. So those should be automatic red flags in your mind as soon as you hear those words, ripping or tearing, when you're talking about quality. So people don't describe heart attack pain that way. That's usually sharp or it's a pressure, but ripping and tearing needs to be very specific keywords to you. Patient's probably also going to have hypotension and shortness of breath. And again, you don't have a lot of time here. So rapid transport is going to be key. Keeping the patient calm, keeping the patient still, quiet, trying to keep that blood pressure low. Don't try to increase it because we don't want to lose more and more blood. So permissive hypotension and rapid transport. Looking at 26, define the following behavioral health conditions and what types of medications might a patient take with these conditions. So we have bipolar disorder. This is a mental health condition marked by alternating periods of elation and depression. So manic and depressive episodes. Some of the medications that patients may take here, these are just some of the most common ones. I'm not going to read through all of them, but lithium is a very common one. Anxiety, this is a mental health condition marked by chronic feeling of worry, nervousness, or unease outside of normal, right? Because if you're going to do something that makes you anxious and that's a normal response, that's not a chronic anxiety. Someone who has these feelings feels them without cause and to the extent that it is interfering with their daily life or daily activities. And so again, ton of different medications that someone may be able to take for anxiety. I'm not going to read through all of those, but you can jot some of them down. And some of these can be used only in an emergency situation when they need them, like Xanax, and some of them are going to be daily medications that they take every day, like SSRI or tricyclic antidepressant. And then same thing with depression. So mental health disorder characterized by persistently depressed mood or loss of interest in normal activities causing significant impairment in daily life. Not, you had something bad happen to you and the normal response to that is a short period of depression. This is depression outside of without normal cause, and that is to the point that it is impacting the patient's daily life. So again, a ton of different medications they can take. These are some of the more common, like Zoloft, Prozac, Alexa, Lexapro, other SSRIs, tricyclic antidepressants, and since that is something we talk about as far as the potential for overdose, I did include some of those medications here, specific list. Pretty much anything that ends in INE, as you can see, this one's just IN, but most everything else is INE as far as tricyclic antidepressants. And then schizophrenia, mental health disorder that affects a person's ability to think, feel, or behave clearly. The patient interprets reality abnormally or becomes out of touch with reality. So this patient's probably going to take some antipsychotics. Those are a few examples. One we should be familiar with is haloperidol or Haldol, because we can also use that as a treatment here for this behavioral health emergency. Doesn't have to just be used for someone with schizophrenia, by the way, but when we think about why does Haldol work so well in behavioral emergencies, it's because these are legitimate chemical imbalances in the brain, regardless of the cause. If it's bipolar, if it's schizophrenia, if it's anxiety, whatever it is, this is a chemical imbalance here that's causing that behavioral health emergency. And so Haldol can be really beneficial there. 27, what's the difference between a mild or localized allergic reaction and systemic anaphylaxis? So a mild or a localized reaction typically presents with only one body system involved, so only itching or skin irritation in one affected area, or like abdominal cramping following ingestion of an allergen. And this can be treated with an antihistamine only, so something like Benadryl to just lessen that redness or itching or skin irritation, or taking medication to help reduce abdominal cramping. But an anaphylactic reaction is systemic, and this is involving more than two body systems or two or more body systems, so multiple body systems like the airway, integumentary, GI, blood vessels, etc. So commonly presents with hives, angioedema, wheezing, hypotension, and it can be life-threatening if it's left untreated. We talked about this earlier, but my first-line medication here should be epinephrine for both the bronchodilation and vasoconstrictor effects, and then can also be followed with antihistamines, bronchodilators, nebulizers, and corticosteroids as needed. 28, what are 3 medications that we can utilize to treat that anaphylaxis we just discussed? And so again, of course, we have our epinephrine 1 to 1,000 at 0.3 to 0.5 given IM. This can never be given IV at the 1 to 1,000 concentration, so 1 to 1,000 needs to be given IM. We also have Benadryl or diphenhydramine at 25 to 50 milligrams IV or IM. And then we talked about the nebulizer treatments as well, but remember Solumedrol 125 IV or IM. So 29, what is the physiologic process that happens within the body after glucagon administration? So I'm specifically talking about for hypoglycemia. So glucagon causes the liver to break down our glycogen stores, and normally glucagon in the body helps maintain hepatic glucose production through this process when the body experiences exertion or stress when the patient is fasting. So remember, glucagon is a normal hormone that's released within the body, so it's all the time should be releasing this to maintain your blood sugar when you are under duress, when you are fasting, when you're not able to eat, when you're running back-to-back EMS calls or whatever. Hopefully you got some good glucagon production, but if you don't, when we administer glucagon for hypoglycemia, that's what's happening. When we give it IM specifically, and that's why we're giving it IM here, in that dose at 1 milligram for hypoglycemia, that's what's happening here, is that the body is causing the liver to break down through glycogenolysis and convert that back to a basic sugar that the body can use to maintain its glucose level. Number 30, how might a patient present who is experiencing an upper GI bleed, and how might a patient present if they're experiencing a lower GI bleed? So bleeding from the upper GI tract, like the esophagus, the stomach, or the first part of the small intestine, typically presents with vomiting blood. And the source of the blood may change the color. So if it's closer to the surface, like the esophagus, it might present as a bright red color. If it's bleeding from the stomach or the small intestines, it may be a little darker, and it may be have an appearance of coffee grounds. Now, bleeding from the lower GI tract, so further down in the small intestine, excuse me, and then the large intestine, the rectum and the anus. This will present with rectal bleeding or blood in the stool. Now, the source of the blood, again, can change the color. So the closer it is to the surface, the brighter red it's going to be. So like right at the rectum from something like hemorrhoids, it's probably going to be brighter red. If it's coming from further up in the GI tract, like from the small intestine, large intestine, and it's coming from the rectum, then it is probably going to be darker in color, and it may be black tarry stools. Both types of GI bleeds are going to have a very distinct smell, and I really cannot describe it to you, but if you've ever smelled it, you know what I'm talking about. But very distinct smell here to both types of GI bleeds. What is the benefit of utilizing continuous waveform capnography? So we mentioned earlier that it is a requirement to utilize end-tidal of some sort to confirm advanced airway placement from office of EMS, but the benefit to continuous feedback is not just used for placement here, like the color change. So with the color change or the easy cap, remember that's the one you put on, give a couple of ventilations, it's changing from purple to gold, we hope, because that's going to say we're in the right spot. But that's all it's good for. It's not going to give you continuous feedback. So when we are using a continuous feedback, like that's hooked to the cardiac monitor, it's going to give us that continuous change, that number reading, and then also my waveform reading throughout treatment, throughout transport, so that I can see, is the patient getting better? Are they deteriorating? Has there been tube dislodgement? Is there something wrong that I need to address very quickly? So continuous feedback is going to be the best option that you can get. 32, what is Beck's triad and what condition are these symptoms of? So we talked a little bit about these earlier, but Beck's triad is JVD, narrowing pulse pressure, so that top and bottom number of the blood pressure getting closer together throughout those trending vital signs, and then muffled heart tones, and those are indicative of cardiac tamponade. But remember, you're only going to see that in the patient with a pulse. If the patient is already in cardiac arrest and you suspect this, you're pretty much just going on your suspicion of blunt or penetrating stress trauma or bruising to the chest, because you're not going to be able to see those signs. 33, describe a situation where administration of Epi 1 to 10,000 may be utilized to treat anaphylaxis instead of the 1 to 1,000 concentration, and what route would it be administered by? So, as we mentioned, the 1 to 1,000 must always be given IM. Now, obviously, the 1 to 10,000 can be given IV or IO. And so why would I do that for anaphylaxis? Obviously, I know I'm using 1 to 10,000 for cardiac arrest, but why would I use the 1 to 10,000 for anaphylaxis? Well, if the patient has significant hypotension or hypoperfusion or hypothermia, there's not enough blood flow out to the muscles to allow that medication to be picked up adequately from intramuscular administration. There's just not good blood flow to those muscles at this point. So the IV administration giving you immediate effects may be more beneficial. Now, that's not to say every single patient who has anaphylaxis who's the least bit hypotensive needs this. I'm saying someone with significant hypotension and hypoperfusion, that's where it may be most beneficial. And then also, again, the hypothermia, just because we're shunting blood, we're not getting good blood flow out to those muscles. Moving down to 34, what are the 3 stages of shock? So what are some notable factors about each one? So we have compensated shock. This is typically marked by an increase in heart rate and respirations, and it may be masked by medications. Pediatrics will compensate for longer than adults. In the decompensated phase, this is marked by that decrease in blood pressure. Pediatric patients are going to stay in this phase for a shorter period of time in comparison to adults. And then irreversible shock, which does not necessarily indicate death, but it does indicate long-term significant damage to organs that have been hypoperfused or had that decrease in blood flow. We're unable to detect this without more definitive testing at the hospital. There's no, outward marker, no vital sign that's telling me I've entered irreversible shock. But it does mean that, like, let's say blood has been shunted away from my kidneys for a long period of time while I've been in these phases of shock, just to help sustain life. And let's say this goes on for long enough and enough blood has been shunted away from the kidney that maybe now I have permanent kidney damage. And that is just one example, because it could certainly be, the heart or the lungs or the brain. But where we have long-term damage, that's going to be what irreversible shock is. Some risk factors for thrombosis or blood clots to develop. Talked a little bit about this when I mentioned pulmonary embolism under obstructive shock earlier. But sedentary lifestyle, and that does not mean just lazy. All right, these are people who could be wheelchair bound, bedridden. Think about people who sit at an office desk all day, truck drivers stuck in that position for a long period of time. That's a sedentary lifestyle. History of blood clotting disorders, blood thinning medications, recent surgery, particularly of a joint, and women of childbearing age taking birth control. All of those should be a red flag in your mind if they are having, if they're presenting with the potential for blood clots like pulmonary embolism. 36, what are the adult doses of the following medications and when would you utilize them as a treatment? The lidocaine, this used to be a huge treatment for wide complex tachycardia. Not so much anymore. I did put it on there, still being protocol dependent. It's not listed on the state protocol, but some local protocols still may use it. So 1 to 1.5 milligrams per kilogram for that wide complex tachycardia if it's being used. Where we would typically see it used now is for awake IO placement and infusion-related pain. So that's 10 to 20 milligrams, which is 1 to 2 cc's for IO placement in an awake patient. And remember, I talked about this when we went over IO insertion. If the patient is still awake and they're having some pain related to medication or fluid administration, we could give that. It's 2 cc's of 2% lidocaine over 2 minutes 2 times. So it's 2 of 2, or 2 of 2 over 2 2 times. But that's where we're going to see it used more often now. Then we have the epinephrine 1 to 10,000. Remember, it is 1 milligram for cardiac arrest, and that's the most common site that we are going to see it used for. But then I did include the information we just talked about as far as the potential use for anaphylaxis. It would still be the same dose at 0.3 to 0.5, but that's why we would use it, which I think we already covered. Now, amiodarone depends on what you are giving it for. So remember, if the patient has a pulse, so VTAC with a pulse, we want to give 150 milligrams per dose, and we're going to give that low and slow. So 150 milligrams through a drip, usually over about 10 minutes. And then for cardiac arrest or pulseless VTAC or VFib, 300 milligrams for our first dose IV push, and second dose will be 150. Regardless of the reason we're giving it, it's always 450 max total. All right. So again, treatment could be used for wide complex tachycardia. It could also be used as a second line for narrow complex tachycardia, like atrial fibrillation when cardizem is contraindicated. So if you remember us talking about that, like in the presence of WPW where cardizem is contraindicated, this may be a good option. And then we have atropine, so 1 milligram per dose or a max of 3 milligrams for bradycardia for adults. It's 2 milligrams per dose and no max for weapons of mass destruction. So those are the times we're going to use this, is symptomatic bradycardia, and then weapons of mass destruction or organophosphate poisoning. So remember, 1 milligram per dose for bradycardia, which is obviously going to be the most common use, and then 2 milligrams per dose, but really no max. Just give it until symptoms resolve for organophosphate poisoning or weapons of mass destruction. 37, so define the following types of seizures. So we have the generalized, which is generally what we think about when we think about saying the term seizure. And previously this was called tonic-clonic seizures. This involves a loss of consciousness and violent full body muscle contractions. All right, so loss of consciousness, full body contractions, usually loss of bowel and or bladder, and usually apnea. And if not apnea, then still not breathing well during a generalized seizure. That's a major concern. Now, a complex partial seizure affects only one area of the brain, but typically presents with isolated or uncontrollable body movements, like movement of one extremity. And this can be with or without the loss of consciousness. And then the simple partial, also called a focal seizure. I did change that from the original one I posted for you guys because I knew what I meant, but it felt confusing when I went back and was writing these answers. So I did change how I termed that on here. So a simple partial is a focal, and this affects only one area of the brain, does not cause a loss of consciousness. It may create issues with ability to focus, speech arrest, or involuntary turning of the eyes or head. This may simply be just staring ahead and kind of zoning out for a few seconds. No loss of consciousness, but just kind of loss of awareness, if you will, for even just a few seconds could be a focal seizure. So what constitutes status epilepticus? A seizure that lasts longer than 5 minutes or having more than one seizure within a 5-minute period without returning to a normal level of consciousness in between seizures. So if you were to have a seizure, go into a post-ictal period, and then seize again without waking up, that is status epilepticus. So if the total seizure lasts longer than 5 minutes, or again, they're back to back without regaining consciousness, that is status epilepticus. 39, looking at the following terms, what do they mean? So hematemesis, that is vomiting blood or blood present in the vomit. Melena, that is our black tarry stools, not to be confused with the next term, which is hematochezia, and that is blood in the stool. And then hematuria, which is blood in the urine. So remember, anytime that we're seeing that hema, that means blood somewhere, then we just have to figure out where it is. Now 40, what is the difference between our sympathetic and parasympathetic responses? Sympathetic is fight or flight. So this is increase in heart rate, increase in respiratory rate, increased blood pressure, dilation of the pupils, trying to let the most light in while your body is under attack, and then a decreased urine and fecal production because the body wants to hold on to the fluid and the nutrients that it has since it doesn't know when you're going to get it again. And then the parasympathetic is a rest or digest, and this is kind of the body's normal operating state. So a little bit lower heart rate, respiratory rate, blood pressure, all normal. Constriction of the pupils, not like constriction to pinpoint, but you don't need as much light let in. So just normal average constriction. And then an increase in urine and fecal production. Your body can operate normally during that parasympathetic. Now, obviously, when you have too much rest and digest, that's where you start getting the signs and symptoms of weapons of mass destruction or organophosphate, which would be sludge. So what are some verbal and nonverbal indicators of a patient's behavior that would lead you to suspect that they have the possibility to become violent? So aggressive or rapid speech, increased volume or tone of speech, rapid movement, pacing, clenching and unclenching of the fist. Those are just a few examples. There are certainly a lot more, but these are some really red flags to you that you may be in danger and that you may need to retreat or call law enforcement if you haven't already. And then 42, these are just some math questions, just as a gentle reminder. For some of you, it's been a little while since we talked about it. So again, 1 gram is 1,000 milligrams. 1 microgram is 1,000 micrograms. 0.01 milligrams is 10 micrograms. 10,000 micrograms is 10 milligrams. And 500 milligrams is 0.5 grams. So just as a short refresher for you as you're gearing up to potentially do some of those math questions you may see on your exam. And then bear with me on this because I cannot remember where I stopped and posted for you guys. I think it was in the 40s, but I did go back and add a few more things on here that I wanted to discuss that you're not going to have on your side. I'll post a finalized copy of this as well, just so everybody has an answer, a copy of the answers to study by, but there's going to probably be some questions coming up that you have not seen yet because I did add a few more on there, so just bear with me on that. So 43, what are the suggested antidotes and dosages for an adult patient for the following medications if the patient is suspected as having overdose on these specific toxins? So tricyclic antidepressants, of course, we talked about a little of those earlier, but the antidote there is sodium bicarb, and the adult dose is 50 milliequivalents on the state. A lot of protocols still have that at 1 milliequivalent per kilogram, so you may see that as well, but it is 50 milliequivalents on the state protocol. For beta blockers, the antidote is glucagon, and remember the dose here is a little different than what we would use it for hypoglycemia. It's 2 to 4 milligrams per dose and really does not indicate a max dose on that. That's what you're giving it for, just until symptoms improve. Calcium channel blockers, antidote is calcium chloride or calcium gluconate. Calcium chloride you're going to see carried more prevalently. These are interchangeable. These are an either or type of situation. Most places do not carry both. So it's 1 gram if it's calcium chloride, 2 grams if it's calcium gluconate. Calcium chloride, like I said, a little more common for us to see in the pre-hospital setting. And then, of course, our opiates, we're familiar with the antidote there being Narcan or naloxone, and that is 0.4 to 2 milligrams per dose. And no real max unless your local protocol indicates that there is a specific max. No max on the state, just 0.4 to 2 milligrams per dose. 44, what are 5 reversible causes of cardiac arrest and their potential treatment? There was a ton of these from that cardiac arrest PowerPoint that I talked about. There's a lot of different reversible causes that we want to consider on that list of H's and T's, but I just picked a few. So hypoxia, of course, that treatment is going to be oxygen and airway management. Hypocalcemia or hyperkalemia, if we're suspecting that electrolyte imbalance, particularly with someone who has renal failure. Treatment there would be calcium chloride or gluconate and sodium bicarb. Tension pneumothorax, we talked about earlier, the treatment there being needle decompression. Trauma, of course, if this is a traumatic arrest related to the injury itself or blood loss as a result of the injury, the definitive treatment is going to be surgery. There's nothing that you can do that is going to benefit that patient more than rapid transport to an appropriate facility for surgery. And hypovolemia, of course, we mentioned earlier, treatment there being blood or fluid, just depends on what we've lost, how we lost it, how quickly we lost it, and what our vital signs are. 45, looking at the following terms. So we have affinity, which is the relationship or attraction of one organism or molecule to another receptor site. So we talked often about how oxygen has an affinity for hemoglobin, but what has a higher affinity for hemoglobin is CO and CO2 and chlorine gas. All of those things have a higher affinity for hemoglobin than oxygen does. So in their presence, they will always be picked up first before oxygen, which can create a dangerous situation. Efficacy, so this is the ability to produce a desired or intended result. So basically, how well is it working? How well does the medication work that you're administering or that the patient's taking daily? And then agonist versus antagonist, something we talked about a while ago. It's been a little while, so wanted to refresh. A substance which initiates a physiological response when combined with a receptor, that is an agonist. And then antagonist is the opposite of that. So this is a substance that interferes with or inhibits the physiological action of another. So it does not cause a response on its own. It's just simply blocking the response of the agonist. All right, so we think about Narcan being an opiate antagonist. Narcan itself does not cause a response. If I were to give it to you, if you have not taken an opiate, it will do nothing to your body. All it is doing, because it has a higher affinity for those opiate receptors than the opiate itself, it will block the response of the agonist, which in that case would be your opiate. Looking at the following conditions, so these are more GI related. So Crohn's disease, this is a chronic inflammatory disease of the intestines, especially the colon and the ileum, associated with ulcers and fistula formation. It presents with abdominal pain, diarrhea, weight loss, anemia, and fatigue. Esophageal varices, this is abnormal or enlarged veins in the esophagus, usually caused when blood flow to the liver is blocked. The symptoms may not be present at all until the veins begin to bleed, and then they're probably going to present with vomiting blood, possibly black tarry stools, and just depending on the amount of blood loss, could be shock symptoms. Peptic ulcer disease, these are sores or ulcers that develop in the lining of the stomach or digestive tract due to acid production, H. pylori infection, or overuse of anti-inflammatory pain relievers. And it may present with abdominal pain in the left upper quadrant, chest pain, nausea, heartburn, gas, vomiting, and fatigue. And then looking at just a few other medical conditions, not really GI related necessarily, but cystic fibrosis, an inherited life-threatening disorder that damages the lungs and the digestive system, affects the cells that produce the mucus, sweat, and digestive juices, causing them to become thick and sticky. So this abnormally thick material clogs those ducts and passageways of the pancreas, the intestines, and the bronchi. The symptoms will vary, but can include cough, repeated lung infections, inability to gain weight, and fatty stools. Multiple sclerosis is a chronic, typically progressive disease involving damage to the sheaths of the nerve cells in the brain and the spinal cord, whose symptoms may include numbness, impairment of speech or muscular coordination, blurred vision, and severe fatigue. Myasthenia gravis, this is a rare chronic autoimmune disease marked by muscular weakness without atrophy and caused by a defect in the action of acetylcholine at the neuromuscular junctions. This can cause weakness in the arms and legs, double vision, and difficulty with speech and chewing. Add that before I forget. Hashimoto's disease is an autoimmune disease causing chronic inflammation and consequential failure of the thyroid gland, usually causing an increase in thyroid hormone, so hyperthyroidism, and presents with fatigue, unexplained weight gain, and other symptoms of Hashimoto's could be like temperature issues, so patient always being cold, things like that. 47. What are 3 normal physiologic changes that happen to a geriatric patient as a result of increased aging? So again, normal, because there's a lot of things that can happen as we get older, but that aren't considered a normal part of the aging process, like decrease in hearing is not part of the normal physiologic process. Some normal things could be decrease in metabolism or gastric motility, which puts us more at risk for like accidental overdose, because remember, if the medications have not been metabolized out and we take another dose, then it's just continuing to build up because the first dose hasn't been taken out yet. Decrease in size and weight of the brain, putting them more at risk for like brain injuries, and decrease in skin elasticity, so poor skin turgor, more easily to dehydrate, issues with temperature management because of that, loss of skin elasticity and turgor. And what quadrant are the following organs located in? So the gallbladder is the right upper quadrant, appendix is the right lower quadrant, the liver is the right upper quadrant, the spleen is the left upper quadrant, and the pancreas is the left upper quadrant. So those can be helpful to you if your patient is complaining of abdominal pain in one of these specific areas, to help you just kind of narrow down and create your differential diagnosis. 49, what are the medications and appropriate doses that you would administer to an adult patient experiencing cardiac dysrhythmia secondary to renal failure, which we mentioned earlier? That would be calcium chloride or calcium gluconate. So 1 gram of calcium chloride, 2 grams of calcium gluconate, and then sodium bicarb, 50 milliequivalents by the state protocol. Again, some local protocols, maybe 1 milliequivalent per kilogram. Number 50. Defining the following terms, so implied consent. This is consent not expressly granted by a person, but rather implicitly granted by a person's actions and the facts or circumstances of a particular situation. So like a person with reasonable decision-making capability would want treatment if they were conscious and or alert and oriented enough to agree to it. Informed consent is permission granted in the knowledge of the possible consequences, typically that which is given by a patient to a doctor for treatment with full knowledge of the possible risks and benefits. So informed consent is required for refusal of treatment or transport. So you have to make sure you say to the patient and that you document that you explained what could potentially happen up to and including death if they refuse. And express consent goes hand in hand with informed consent. They are expressing this themselves. They are outwardly agreeing to their desire for treatment or transport, and they must be informed to do so. 51, what is thrombolytic therapy and when may it be utilized? So the use of medications to break up or dissolve clots, that is thrombolytic therapy. So patients fitting within that time frame or window to receive the treatment for clot busters, for those who are experiencing STEMIs or ischemic strokes that are related to blood clots. And that time frame window really just kind of depends on what type of thrombolytic therapy they offer in the facility. So some facilities have that window at 6 hours, some have 12 hours, some have 24 hours. So it really just depends on their complaint and the facility and their abilities. 52, what are the responsibilities of the following people during an MCI? So your triage officer is responsible for ensuring triage of all victims and directing movement of patients toward the treatment and transport areas of an MCI. They are responsible for communicating patient counts and needs for supplies and personnel to the medical branch director and communicating movement to the treatment officer. Your staging officer is not specific to a medical incident and does not fall under a medical branch. They report directly to and communicate with the operations chief, section chief, or the incident commander. All vehicles and resources assigned to an incident will initially report to a staging area managed by the staging officer. The treatment officer responsible for managing the treatment area, including assigned roles of personnel, supplies if the medical supply management role is not assigned, and coordinating with the triage officer for movement of patients into the treatment area and the transport officer for the movement of patients out of the treatment area. And then the transportation officer, responsible for arranging, tracking, and documenting the transport of patients from the scene to an appropriate facility. Communication with the incident commander, the treatment officer, and whoever is in the communications role. If the communications role has been assigned, it may be that person who is contacting the hospitals to establish the ability to receive these patients based on the number and acuity level, like how many trauma patients can they take. But if that's not been assigned, then that may be the responsibility of the transportation officer. 53, what is subcutaneous emphysema and when might a patient present with this? So air becoming trapped in tissues beneath the skin. This can occur as a result of trauma, infection, or certain medical procedures. It presents with a crackling feeling underneath the skin. So this would be described like touching Rice Krispies and occurs most often at the neck and the chest. 54, how should you manage an impaled object and are there any exceptions? We want to leave the object in place and stabilize it. The exceptions to this are if the object is interfering with airway or airway management, or if the object is impaled in the chest and the patient requires CPR. Those are the only two times that we should remove those objects. Otherwise, we want to leave it in place and stabilize. Looking at the following terms, again, these are the 3 P's of a diabetic patient. So polydipsia, increased thirst, polyuria, which is increased urination, and polyphagia, which is increased hunger. And so 56, again, going hand in hand, when might these symptoms manifest? And that's usually with hyperglycemia. And that could be someone who has known, suspected, or even undiagnosed diabetes. If they have that increased thirst, increased urination, increased hunger, because if we think about how that works, when this glucose is building up in the blood, remember I said it's going to spill over into the urine for the body to get rid of it. So you're going to have increased urination as the body's getting rid of that. Well, the more you're getting rid of, the more dehydrated you're getting, that's going to increase your thirst. And also the body wants to water down that sugar. So it's telling you it's thirsty because it wants water, not Mountain Dew. So what do we typically give it? Something sugary, which is only making it worse. And then polyphagia being increased hunger because we're not able to digest and break down and utilize the nutrients from our food here. So even though we're eating, we're still hungry. Nothing is satiating that hunger. 57, how should a pediatric patient be transported in an ambulance if they are not experiencing any life threats? Well, if their car seat is intact, then we can use that if possible, securing it to a seat or to the stretcher with appropriate restraints. If they were in a motor vehicle accident and their car seat is intact and there's no serious injuries to the patient, then we can still leave them in the car seat and apply pads around the head to help stabilize the spine. But if the car seat is not an option because they don't have one, it's not with them, or it was damaged in an accident, then an appropriate pediatric restraint device should be used. 58, what are signs and symptoms of Cushing's triad and when would a patient experience these? So Cushing's triad, that systolic hypertension or a widening pulse pressure. So we talked about narrowing pulse pressure. Widening pulse pressure means the top and bottom number getting further away. So systolic hypertension, the top number is getting bigger, bottom number is getting smaller, that number is widening. And then bradycardia and irregular respirations. These are indicative of increased ICP or intracranial pressure. This is usually caused by a head injury, bleeding in the brain, hemorrhagic stroke, tumors, infections, excess cerebrospinal fluid, or swelling in the brain. Now, again, remember, the only definitive way for the hospital to treat that increase in ICP is going to be to relieve that pressure, whether that is to create burrow holes to allow for room for the brain to swell, whether it is to remove that excess cerebrospinal fluid, like with a shunt, or it could be for us in the pre-hospital setting to help with hyperventilation. So that's 59. So how can that induced hyperventilation help reduce intracranial pressure? Well, increasing the ventilation slightly, so one breath every 3 seconds, not like 65 times a minute, but one breath every 3 seconds can help decrease the intracranial pressure and relax the brain, because hyperventilation will cause hypocapnia or decrease in end tidal, which causes vasoconstriction in the cerebral arterioles, reducing cerebral blood flow and cerebral blood volume to an extent which will temporarily decrease ICP. And then 60, which is the last one on my list, what is MRSA and how can it be contracted? So MRSA is a methicillin-resistant Staphylococcus aureus. This is a group of gram-positive staph bacteria that are distinct from other strains. It's responsible for several difficult-to-treat infections that do not respond to regular antibiotics or treatments, and it's spread by contact with infected people or things that are carrying the bacteria. The carrier may have these bacteria lying dormant in their body for years until an infection resurfaces again and again, and this person may be contagious indefinitely. It's not airborne, got to be spread through by the person to the object or whatnot. And commonly, people will pick this bacteria up in the hospital, especially if they already have a weakened immune system. So that is it as far as a study guide review, both for your midterm for my hybrid guys and for final exam for my seated guys. If you have any questions about this, or if you're watching the replay of the video later on and have any questions, please feel free to reach out to me. Otherwise, if you guys have any questions, shout them out to me now. All right, if I got no questions, I'm going to end this session. Thank you, Jeff. Thank you guys for hopping on with me and hanging out. If you think of a question later, please email me. But I'm going to end the video here and post the recording under Collaborate.